I'm going to mute it out after a few minutes here.
All right.
Okay. We've got 5 people. I just want to start, then I'm going to start by introducing you, Zena. So, Assalamualaikum, everyone. Can you guys hear me? Okay, perfect. Thank you. Yes. So we have Zena. Can you pronounce your last name?
Yeah, Zena Dadouch.
Zena Dadouch. Zena Dadouch is our psychologist today. Jazakallah for giving your time, Zena. Zena's got a bachelor's from University of California, Berkeley, and then her PhD in clinical psychology from Northern Illinois University with a training emphasis in trauma psychology. She completed clinical training in the assessment and training of trauma outcomes and post-traumatic stress disorder. She also completed a residency year at UC Davis Medical Center, working with children and adolescents with trauma and psychosis-related problems. She also has experience in the treatment of areas of psychopathology, such as depression, anxiety, and emotional dysregulation. Dr. Zena has had clinical experiences in a variety of settings, worked with all age groups and families. Currently, she's completing a postdoctoral fellowship at Austin Child Guidance Center, a nonprofit clinic in Austin. Her background is in evidence-based treatments, and she comes from a cognitive behavioral theoretical orientation. Dr. Zena also integrates clients' religious, spiritual, ethnic, racial factors within treatment and has a newfound interest in Islamic psychology. And my apologies, Zena, we have your wrong email on that. So if you can correct your email and tell us a little more, and I'll let you take over from here.
Yeah, so the email address that was on there is not accurate. So I'm going to put it in the chat just so that people can have it. But it's Zena Dadouch at Austin Child Guidance. I'm just going to put that in the chat for people. Okay. Do you want me to get started?
Yes, please. Yeah.
Okay, perfect. So I'm going to share my screen. And if y'all can let me know if you see the slides, okay? Yep.
There you go. I see your slide.
Okay.
Yes.
Okay, great. So thank you for the introduction. I'm glad I see a couple people here. I know it's spring break, so everyone's sort of busy and traveling and things. So appreciate everybody who's joining. So I am gonna try to do a very broad presentation today on trauma and PTSD. And because I've experienced with both children and adults, I'm also gonna try to cover sort of the differences that we might see between, the age groups and what you might be looking out for if you have kiddos who've had some trauma, or if yourself or your loved ones have had some trauma exposure too. So it will be a kind of broad presentation today. At any point, if you'll have questions, just put it in the chat, unmute, whatever you need to do. I'll be happy to answer questions as we go along, versus sort of waiting until the very end. All right, let's see. So, I think it'll be helpful for all of us to sort of start off with just understanding a little more what we mean when we say the word trauma, because I think a lot of everyday conversations and sort of just in general social media things that we have noticed in the field, at least, is that people are using trauma either too lightly or not really emphasizing when trauma is occurring, that it is actually trauma. And so to start off, I wanted to make sure we're understanding what a clinical definition of trauma really means. And this definition is going to be from the DSM, which is our diagnostic and statistical manual that we use in the world of psychology, which really is sort of a book that we go back to for diagnoses and different definitions of different disorders. So this is really the kind of official definition of what a trauma clinically means. But beyond that technical language, really a trauma is any time a person is exposed to death, whether it's an actual death or a threat of death, or exposure to serious injury, whether physical or emotional. There's a lot of different types of violence. It could be physical violence, sexual violence, emotional violence. And all of these exposures can happen in multiple ways. So it's not just that it can be happening directly to you, but that's one way. So, you might be in a car accident, or number two is when you witness an event happening to another person. happen. So you could witness a car accident. You can hear about it happening to someone that you love, or a close family member or a close friend. So that's the third way you can be exposed to it. And then the last way, which I think oftentimes has been confused with a lot of use on social media, is that when you are repeatedly exposed to certain types of trauma exposures, we could see you develop PTSD symptoms, and we'll talk about what PTSD later, or what PTSD is later, but really this has to be in the context of a career or a job. It can't just be that we're watching the news and we're watching a lot of traumatic content. That doesn't really count, even though it is of a traumatic nature. Clinically, that's not really what we're meaning when we say you have direct exposure through media to different types of traumatic events. So it's got to be like a police officer or a journalist or, a telecommunicator. So when we call 911, those are the types of repeated exposure through your work that would count. If you're on TikTok or if you're on social media and you're watching a lot of traumatic content on there, it's not really our clinical definition of what a trauma is, even though it is harmful, and it's not very helpful for us to be exposed to a lot of that stuff online. Excuse me, I'm a little sick, so a little bit of sniffles. But beyond that, those are kind of the 4 different ways you can get exposed to trauma. And again, it's not just with adults, it's also with children. Even young children can be exposed in those types of ways. And so in any of those sorts of exposure, you can be considered to have a clinical exposure to trauma. So essentially, really, it's any event that's incredibly emotionally stressful. And oftentimes it's very short-lived. And so it's not happening for a very long period of time. And so you can imagine, a car accident happens fairly quickly versus compared to other types of trauma that can be a little more chronic and enduring, like domestic violence or childhood abuse, or for a lot of us in the last few years, COVID-related trauma exposure has been very enduring and seems like it's endless, especially for those of us who work in the medical field, or if your loved ones work, as frontline workers or teachers or doctors, that has been a very enduring trauma, kind of nonstop over and over again. So those are more our chronic trauma exposures, but oftentimes we're having trauma exposure in a very short period of time, and it doesn't last very long. Those that are happening for more enduring time periods are the ones that are going to cause the highest risk for later outcomes that are worse. For example, domestic violence is not often happening 1 time or 2 times. It's very ongoing process, and we see a lot of poor outcomes coming from exposure to domestic violence. Same with sexual abuse or physical abuse. It's not usually happening 1 time, and it's often happening over and over again. And when we see that you're getting this exposure early on in your life, so as a child or as an adolescent, this also increases your chances of getting more trauma exposure in your adult lives. And so again, it's really important to start learning what a trauma really means so that you can identify it in your own families and in your own kiddos or friend group even. So this is, again, essentially what a trauma really means. And I don't want to get too technical with like numbers and statistics, but I thought it would be helpful for us to also learn how often we are exposed to traumas. And so generally, we know that most of us at any point in our lives are going to have exposure to trauma, and often more than 1 type of trauma. And so about, the estimate is about 90%. We're all, most of us are going to have some type of trauma. And again, this is a clinical trauma, not kind of what we use colloquially as a trauma. And so we, most of us are going to have this exposure. And then the rates of PTSD, and again, we'll get to what PTSD really means a little later, are not happening to the 90% of us. And so it is lower, it is much, much lower, which is a good thing. And the lifetime, at any point of our lives, about 99% of us are going to meet for the diagnosis of PTSD. So it's, again, it's kind of a good news, situation. We're all getting exposed to a lot of trauma, but not all of us are developing a clinical diagnosis diagnosis or clinical disorder from it. And what we know also is that those who are seeking treatment, so what we call clinical samples, those who are presenting to clinics and hospitals seeking mental health treatment, again, majority of them have had a trauma, if not more extensive than one event. And so oftentimes they're coming with a lot of different traumatic events in their lives. And so it's very common. We are seeing a lot of trauma, and this is not really surprising. When it comes to different age groups, again, because we're looking at children and adults in this presentation, I kind of wanted to divide and highlight some differences. For young children, under age of adolescence, really, and this is probably an underestimate, but we see that 1 in 7 children at least will have one traumatic event. And again, by the time you hit the age of 16, majority of children are reporting at least one traumatic event. And again, this is probably a very low underestimate. And so we want to identify those things early because it really matters with how quickly children develop and the different developmental stages that we go through. By the time we hit adolescence, trauma can play out in different ways. And so the earlier we detect it, the better it is. We also have this area of research that we call the ACEs research, or the Adverse Child Experiences. And it's sort of this list of events that you can have as a child that you've experienced. And the more you experience them, the higher your chances are of having worse outcomes physically and mentally. And so the number is that if you have more than 4, we're having like exponentially worse physical health outcomes, way worse mental health outcomes. And examples of these include things like parental separation, somebody in your family attempting suicide or committing suicide, physical abuse, emotional abuse. And if you think back to your own lives, I'm sure a lot of us are meeting at least for one of these ACEs, but the more we have experienced those, again, once we get to 4, we're seeing a lot of really strong evidence that it's leading to way worse outcomes. And so this is a very big area of research in childhood trauma, because we really want to start preventing ACEs from happening before they actually happen, versus kind of looking back and doing more like what could we have done, type of research. And so again, because it's really important to look at trauma across the age groups, the earlier the detected trauma exposure, the better. And so there's, I just wanted to put in a resource here for folks. The National Child Traumatic Stress Network is a really, really good, helpful network for both parents and teachers and all sorts of people who have kiddos or work with kiddos. A lot of resources on there for assessing trauma and trauma treatment and things like that. So that's just for your own use. And then for adolescents, again, not surprising, majority have had at least one traumatic event. We are seeing higher PTSD rates in adolescents, females than males. And so that's a very common theme that we notice. And those adolescents who are not living with both of their parents and already had some type of behavior disorders or behavioral problems as a younger child is most likely to experience worse outcomes from their trauma. And so just sort of a few things to keep in mind. Similarly, it's higher again among females. If you've had more trauma exposure, if you had multiple traumatic exposures, particularly interpersonal violence. And when we say interpersonal violence, we really just mean when it's an event that's caused by another person. And so it's not necessarily an earthquake or maybe a car accident. It's more a person sort of intended harm to another person. It could be physical abuse or sexual abuse or domestic violence. All of that counts under interpersonal violence. For ethnicity, again, not surprising, unfortunately, is that we know this is one type of research, but generally ethnic minority college students that are not white basically are more likely to report trauma exposure as a child, and their families are more likely to report exposure to community violence, like seeing a beating or physical abuse of somebody else. They're also reporting more physical abuse as a child, and just overall higher levels of traumatic exposure which again leads to higher chances of developing PTSD and other problematic disorders. And this reflects to the general population. So if you're not a college student, or if you don't have college students in your lives, this is so important to keep in mind, as a lot of us belonging to ethnic minority groups are not really emphasizing the importance of thinking about our own traumatic exposures, and often kind of saying it's no big deal, it happened in my family, all the time, this is our normal. Sure, it might be the norm, but it doesn't mean that it's not something we should pay attention to and maybe do something about, at least for our own selves. And again, not surprising, more data on trauma occurrences. We know that if you are belonging to a lower income background or coming from a lower SES background, you are experiencing and reporting a higher rate of traumatic exposure. And I'm sure y'all can guess why, whether it's community violence, whether it's crime, whether it's all types of socio and economic factors that work together to lead to higher trauma exposure. We also know that women from low SES backgrounds, that usually comes with lower education levels, often report much more severe interpersonal violence and also higher rates of childhood sexual abuse. And so if you're living in the Austin area, and I'm sure you already can guess, especially belonging to different neighborhoods and different messages, we really need to keep this in mind when we're looking at trauma exposure. A lot of us might be moving to Austin, and we're not really familiar with the different socioeconomic histories of the Austin neighborhoods and things like that. And we really may not see this, very often in our own messages, but it's really important to keep in mind, whether you're a provider or you're just kind of a community member. This is something that's not often talked about, especially in Muslim communities, is SES and different gender groups and differences between those is something we should always keep in mind. I already said this, I'm just going to move on. And then the last thing I want to say really about trauma exposure is that we often see this re-victimization, which is essentially you're more likely to experience another type of interpersonal trauma because of trauma that you've already had. And so it's very much this vicious cycle that often needs a lot of intervention to get out of. And this is really kind of for a variety of reasons, including that your mental health already is at risk from exposure to maybe the first type of trauma that you've had. And so you might develop depression, you might develop PTSD, which then puts you at a higher risk for experiencing more trauma exposure. And then like I said earlier, you start thinking that this is normal. This is just what life is like in this household. This is just what life is like in this neighborhood. This is just what life is like being a part of this ethnic group or that racial group. And so your norm becomes, your baseline becomes that violence is normal. And so you're not going to detect more levels of violence that tell you, okay, maybe I should get out of this situation, or maybe this relationship is not great for me, or maybe I need to seek someone's advice. And so you are not able to recognize risk as much as you would if you weren't exposed to this much trauma to begin with. And so that, again, that leads to a lot of families having this problem where people don't know what to do. They're not sure, they identify that this is a trauma, they identify that this is a risk, but I still don't know what to do about it. I'm not able to just leave my partner or my husband or my wife. I'm not able to just, as a kid, leave my family, even though there's abuse in my household and domestic violence. What am I going to do? And so you're often going to see a lot of people who are going to become re-victimized, meaning they're going to be exposed to trauma over and over again. And even if children grow up and they're able to leave their households, that doesn't mean that they're not going to, again, get into relationships in the future, get into situations in the future that to them is normal, but it is violence or it is traumatizing. So a lot of these things unfortunately are not going to just happen one time, and they're going to be an enduring cycle. And so that's generally what kind of the trauma statistics, trauma prevalence, what trauma really means. And now I kind of want to shift a little bit and talk about what it's going to lead to after trauma happens. But I just want to see if there's any questions, before I move on. And if not, I don't see any in the chat, so I'll just kind of move on for now. After we it sounds really, negative and not very optimistic, but well, the good news is that a lot of the trauma outcomes are very, very treatable, and that the rule, like you saw in the statistics, although most of us are exposed to trauma, the general rule is that we are resilient as human beings, alhamdulillah, which is good. And then we also know that those who are going to suffer from different mental health disorders, it is very treatable. And we have a lot of different treatments that we're going to get to towards the very end that are, again, helpful for people once they seek the help and are able to work on it. But before we get to those treatments, I do want to cover the different ways that you can see trauma in the various sort of groups or the various age groups that we see. I do see a question in the chat. Let's see. Any genetic disposition to behavioral response to trauma? Yes, there is some research that shows, that based on different personality traits, based on different family backgrounds, you might see more likelihood to experience things like PTSD or depression or substance use. And so there's definitely a lot of research on genetic dispositions and risk factors that might put you at a higher likelihood of experiencing different trauma outcomes or disorders. It's probably beyond the scope of this presentation, but off the top of my head, those of us who are a little more neurotic, and neurotic really just means that you're more likely to experience negative affect, you're more likely to be nervous and worried and a little more pessimistic or a little more sort of, have a negative view of the world. That is a genetic trait. And so, those of us who are sort of temperament born that way are probably more likely to experience different trauma outcomes versus to be more resilient. We also know that perceived social support is really important. And so it's not really your objective social support, but it's the way you view your social support around you. So for those of us who have maybe a small group of support, but we see them as very, very important and very, very powerful, we're gonna do better when we're exposed to trauma versus those of us who maybe have a lot of support objectively, but we don't see it as very supportive. Maybe we don't consider them a social support circle, or those of us who don't have support at all, we're not seeing that we have support. And so that also can play a big role in your resiliency or not. And the way you view your social support is also sort of tied to your genetic predispositions, especially your personality traits and your temperament. So there's a lot in there, but really good question. Hope I answered it a little bit. Okay, so maybe there are some medical doctors and medical professionals in this presentation today or watching it later. I'm really going to dumb this down. This is not going to be a very biologically based explanation, but I wanted to cover it for those of us who are unfamiliar with it. But, subhanAllah, we're all born with this response system that we have that is meant to keep us safe in face of any threats. And so, when you are facing a threat, around you, your body, kicks into this response that we call the fight and flight response, which is really an alarm system that tells your brain tells your body, you got to get out of the situation. This is scary. This is dangerous. And I want to keep you safe. And so we either fight or we flight, meaning we run away from the threat that's around us, or we freeze. This is sort of another way where you kind of just don't know what to do and you maybe pretend that you're dead or pretend that you're not there. And this alarm system, again, is activated when we see any perceived threat or danger or trouble around us. And so it leaves really those kiddos and adults feeling confused and scared and, again, wanting to get away from the situation, or sometimes you want to withdraw from the situation. And so that's a general healthy response that we see in our bodies. And again, subhanAllah, it's meant to just keep us safe. When it comes to trauma, I wanted to introduce it because what we see is that this system is often activated, even though we don't have threats around us. And so just kind of to give you an example, and again, this is very simple and it's, it's very, very, it's just meant to give you an idea of how it can go wrong. But basically imagine you're, taking a walk around Lady Bird Lake. I don't know if there's snakes there, but let's just say there's a snake and you run into it and you might, again, go into this, you're going to go into this fight, flight freeze response. And some of us might react differently. You know, I'm definitely gonna run away. I'm not gonna fight this snake. I'm not gonna freeze either, because I just don't do that. But some people freeze, right? They just don't know what to do. They're afraid of the snake. They're just gonna kind of be stuck in motion. And then some of us might fight it. I don't know who's gonna fight the snake, but it's a possibility, you know, you might end up doing that. All of this is just to keep you safe. And it comes with a lot of different physiological reactions. Like your heart rate will increase, your breathing will get heavier, just to get more oxygen in your body, and, you know, get your muscles ready to either fight or flight, or even freeze. And so again, healthy response so far. And then let's say the next day or the next week or whenever, you know, you're taking the walk again, you're hiking again, and you see like a garden hose instead of a snake, and it triggers this reaction in your brain that this is a threat, because it looks exactly like the snake, even though objectively it is not a threatening object. It is just a gardening hose. And so we can see that happening. And we do see that happening over and over again with trauma and PTSD, is that your brains, you know, our brains are very, very advanced, very, very amazing function on their own, you know, but sometimes they fire incorrectly, and we have an alert go off in our brain. We have an alarm system go off, even though there is no threat around us. So we see that again over and over again when it comes to PTSD and trauma. And that's why we're seeing a lot of those symptoms happening that we're going to get to, I think, in a few slides. Your stress response system is hyperactive. And so it's always turning on and on and on. And that leads to a lot of physical health problems and also a lot of mental health problems. And so a lot of the points of trauma treatment is to let you sort of identify what's a threat, what's not a threat, how am I able to kind of get control back of this system, because as of now, it's just always on. I'm seeing threats everywhere. I'm not being able to live my life in a relaxed way. I'm very hyper vigilant of everything around me. And the common example that people use really are kind of veterans, because a lot of the research has happened on, you know, veterans coming back from war. Everything is a threat around them. You know, fireworks sound like bombing. We see that they can't really sit in a place without seeing the exit signs, because they're always thinking there's going to be an attack. I have to get out in this situation no matter what, even though it might just be a mall or a restaurant. And so again, that's kind of a classic example here. But a lot of us with other types of trauma exposure, maybe not war exposure, but more domestic violence, you know, you might see threats in all types of males. Let's see, if your abuser was a male, then okay, all males are dangerous. Even a store clerk might be dangerous. And so I'm never going to be able to go to a store because there is males everywhere. And so again, you can imagine how that's going to lead to a lot of difficulties living your life. So that's, again, very dumbed down version of fight and flight response, but I wanted to introduce it because a lot of times, especially parents, don't understand why their kids are so active. Why are they so angry? Why are they always temper tantruming all over the place? And this is really related to that reaction that kids are just feeling out of control and in danger. And again, we'll just get to that in a little bit. So this type of reaction that's always on, you know, can lead to a lot of different diagnoses and different disorders that are kind of our formal trauma outcomes. But PTSD is the big one. And PTSD really just means, stands for post-traumatic stress disorder. So you have a trauma, after the trauma, you're going to have this disorder. Without the trauma, you are not seeing PTSD diagnoses. It's not like depression, where for depression, nothing really has to happen for you to develop a depressive disorder. But with PTSD, really, really specifically, you need to have that trauma exposure for you to be able to get that diagnosis. But we also see depressive disorders with trauma outcomes. They're very, very common. We see substance use disorders, and these are not very talked about in our communities because they're very stigmatized beyond just general mental health conversations. And substances can be anything. It does not have to be alcohol or drugs. It can be smoking. It can be other types of addictions. I'm just putting substance abuse here because that's sort of a general term. but maybe I should have put in addictions, but really we might see all sorts of abusing of substances and things in our lives as a way to escape the trauma that we have experienced. TBI is, traumatic brain injuries are more our physical traumas that are happening, maybe car accidents or abuse or violence that leads to TBIs, but that's another one that you can see, and it leads to a lot of different memory problems and more physically based difficulties. And then these are not the full list. We're seeing a lot of other psychological and medical conditions that can happen from trauma exposures. But the main one I'm going to talk about today is PTSD, because I think it's often misunderstood, and it's really important for us to understand what PTSD looks like to help ourselves and other people. And so, like I said, you really need that traumatic exposure to have PTSD. So that's sort of the first criteria that the DSM-5 or that manual I was talking about earlier, that you need to have in order to be able to get this diagnosis. And then you need this second set of symptoms that might sound familiar to a lot of us who maybe have had this experience ourselves or people in our families, but you're having those memories of the trauma pop up in your head, even though you don't want it, you're not thinking about it, but you're having a hard time controlling it. And that's why it's intrusive, meaning it just comes to you when you're not wanting it, you're not thinking about it, and it's often unpleasant. And so you're not having a beautiful dream of the person that you've lost. It's usually very upsetting. It's usually one you're not enjoying. Perhaps it is more about their death and not about themselves as people. So that's kind of when it comes to a loss of a loved one. You're having memories of what happened, perhaps like the actual loss or the actual incident. Again, when you don't really want those memories to happen, you're not consciously thinking about it. They just pop up in your head. For kiddos, a lot of the times it's nightmares. You're having a lot of nightmares and bedwetting, and it's really, really distressing for the kiddo. And even when maybe I'm talking to you about it, you're having this reaction. You're having this an inability to be kind of consciously talking about it. And so you might have dissociation, where you're just not wanting to be there, not wanting to talk about it, not wanting to think about it. And so just the memory of the event in itself is so distressing that you cannot just sit with it. And so that's sort of our first category that we look for. If you're talking about your trauma, okay, if you're able to discuss it and share it with people, if you're having dreams about it that don't bother you, if your memories of it are totally fine, you're probably not meeting full criteria for PTSD. It might still be bothering you that it happened to you, but we really need that piece where just thinking about the trauma, just remembering the trauma is incredibly difficult for you. And then we have this second set of symptoms that we call avoidance. So this is a general term that we see with a lot of different fears in general. So, if you have a spider phobia, you're going to avoid spiders. It's very straightforward. If you have a fear of heights, you're not going to go up to the tallest building or, skydive or do all those other types of things. But when it comes to trauma, it's really, really much more complicated, because it's not like you're going to lose a person every day or be assaulted every day. And so what you're avoiding is not necessarily the trauma itself. It's just things that remind you of the trauma. And so you don't want to think about it. We've already talked about this one. You don't want to have memories of it. And so when you do have an intrusive memory, you're wanting to avoid it. And so these two get into a cycle, because the more you want to avoid these memories, the more they happen. That's just sort of how it works, unfortunately. So you're avoiding thoughts about it, you're avoiding talking about it, you don't want to see people that remind you of it. So let's say your trauma was a domestic violence incident. Perhaps it was a family member or a friend. You're going to obviously avoid that person, but then you might start also avoiding people that are related to that person. You don't want to see their spouse, you don't want to see their kids, you don't want to see their family, you don't even want to go to the masjid anymore. Maybe you don't want to go to live in Austin anymore. A lot of those things are going to start impacting your life because you just don't want to be reminded of what happened, because it's uncomfortable and it's distressing and it's scary. And so you're just going to avoid it at all costs. You might avoid the place that it happened. Let's say you got in a car accident on I-35, you're just not going to take I-35 anymore, which is possible and okay until it's not. And so we do see that oftentimes, again, avoidance, even of places, is going to cause you to change something in your life. And that's why it's becoming, it's meeting that criteria for dysfunction and a disorder. And so avoidance can look very different across people and across different traumas that we see. With COVID specifically, both of those things have been often happening for a lot of us who are kind of every day dealing with COVID. You don't want to think about it, but every day you're going back to work and you're thinking about it and you're seeing it. And so it's kind of impossible to avoid, but you try still anyway. So sometimes avoidance is just the effort of avoiding it. You're not able to avoid it all the time, but just the fact that you want to avoid it so much is indicative that there is this stress happening. And when you think about it, and you just don't want to be reminded of it at all costs. So that's kind of the general avoidance category. And then we also have, and this one seems a lot like depression. And that's why we want to see the first two symptom kind of clusters or umbrellas of symptoms before we see this one and say that it's PTSD. Because if I tell you, somebody's feeling really sad, somebody's having a lot of negative thoughts about themselves, they think the world is unsafe, they think the world is dangerous, they think people are terrible, you're not interested in your hobbies anymore, you're not eating anymore, that alone sounds like depression. But then when you add that there was a traumatic event, when you add that they're avoiding a traumatic event, when you add that they're experiencing those intrusive memories, then altogether it's more indicative of PTSD and not just depression. And so what we tell people is that you might just look at this cluster of symptoms and think, oh, my blah, blah, blah has depression, or, oh, myself, I have depression. But that's why this presentation hopefully will help people identify that there's other things happening too. It is not just depression, the treatment is different. And so that's why we really want to differentiate between them. But we do see a lot of those negative symptoms happening in people and kiddos with PTSD. And then finally, we're having this hyperarousal. And this kind of ties back to the fight and flight response that we talked about earlier. And so you're always on edge. You're always feeling like you can't relax. You have a high level of arousal or reactivity in your body. With adults, this can seem a lot like you're just always angry. You're just always kind of pissed off and irritable. You might be always kind of driving really fast or doing all sorts of risky things, including kind of spending a lot of money when you don't have it, kind of ranging from that to just reckless behavior that's physically unsafe, whether it's driving really fast or, doing drugs or other sorts of dangerous, risky situations. The example I gave earlier of kind of sitting in a restaurant and always needing to look at the exit sign and not being able to sit with your back to the exit sign, that's another sign of this hypervigilance, is that you expect danger. And so you're always acting as if you should be ready to escape this danger. The strong startle response is interesting. A lot of us just have this in general, but if you're having other things as well, you might, if you hear a loud sound, you're very, very jumpy and you're startled super easily, again, because your body physically is always ready to fight or flight whenever a danger can happen or will happen. This is important for kids, but when you're having a hard time concentrating, because again, you're always unconsciously thinking of the danger that might happen, your teacher might say you're not paying attention, or you're such a bad student, you're not doing your homework, and all of these things are tied, obviously. So the less sleep you have, the less the less you're going to be able to concentrate, the more you're going to want to get out of there. And so again, all of those things are super, super tied with each other. And if you're an adult and you're working and you're not being able to work really well because you're having a hard time concentrating, again, all of these things are super tied with each other. And so all of these symptom clusters together are going to tell us that the person is probably experiencing PTSD. And we are, again, good news is that we have a lot of different treatments for PTSD that are kind of easily treatable with the right effort and time. All right, let's see. For general rates of PTSD, if people are interested in this one, we know, again, unfortunately, that women not only have higher rates of PTSD, we see that their symptoms last longer than males. And that could be for genetic factors, and it could also just be for the types of trauma that women experience and the type of social kind of factors that play out, especially when it comes to interpersonal violence. You're not able to escape as easily domestic violence. You don't really have a backup to go to when you're in those situations. And so that might be a part of why women experience symptoms for longer and experience more PTSD. Another factor is that males often don't want to seek help less than women, and so they're just not coming to research settings or clinic settings. And so maybe men are experiencing more PTSD, we just don't know it because they're not seeking the help as much as women do. So that's another thing to keep in mind. If you're a male, or family members are experiencing those things, encouraging them to seek the help when they need it, knowing that males are less likely to seek help when they're going through something that's difficult. We also see that PTSD is higher in younger populations than older, and that could be for other reasons, like social support might be just weaker when you're in those, different stages of life, and you're going through a lot of changes, versus you're more established, you have a family, you have more support. That could be a reason why we see PTSD rates higher in younger populations than older. Again, unsurprisingly, just like we saw that we have more trauma exposure with low SES backgrounds, we see the same for PTSD. We see higher rates of PTSD in individuals who are coming from lower SES, disadvantaged, under-resourced environments, both about income and education. So those are a really kind of easy target of intervention. And then again, with higher exposure, you have higher risk of developing PTSD. And those who have had a lot of injury, so a lot of physical injury from their traumas, tend to have higher rates of PTSD as well. And so the physical aspect is tied to the mental health aspect here. And then, again, not surprisingly, when we're having those interpersonal types of trauma exposures, like your partner, your husband, your mother, your father, it seems to be leading to a higher rate of PTSD, and specifically higher rates of mistrust and not being able to accept that the world can be safe and is safe, as opposed to the world is very dangerous and no one can be trusted, and those types of beliefs as well. This interesting one, during the trauma exposure, we know that if the person thought they were going to die, this is something that crossed their mind. They were thinking, absolutely, there is no way I'm going to survive this. This unfortunately leads to also higher rates of PTSD, even though maybe the event itself wasn't as dangerous, or was dangerous, but was very, very fast, and it was a one-time event. So this is an interesting one that we see as well. So the perceived level of fatality of the event can also really be tied to whether a person has PTSD or not. I wanted to emphasize a few differences in children under 6, because I think, again, if you're a parent yourself watching this, or if you are knowing a parent in your life that has young kiddos, it's very, very important to keep those differences in mind, because they're not going to come up, a 6-year-old or a 5 or 4-year-old is not going to come up and tell you, I think the world's unsafe and I don't trust people. It's just not going to look that way, but they can easily meet criteria for PTSD, and they can be diagnosed as young as 1, 2 with PTSD. But we just have to know what it looks like to be able to identify that this is not just them temper tantruming, this is an actual problem. And so, the first item on this list really is that young kids are not able to express their thoughts and feelings as easily as ideally adults do, but even adults have a hard time with this. But let's assume adults do a better job at this. Young kids are not going to be able to come and tell you, I'm feeling very scared and confused and disgusted, and I'm having those thoughts that the world's unsafe. They're not going to do that. What they're going to do is show you that they're very angry and annoyed and sad. And they're going to cry a lot, and they're going to, for no reason, they're going to be acting up and not listening. They might be hitting kids on the playground. They might be hitting you as their parent. They might just have these extreme temper tantrums and you don't understand why. And it's very confusing for you and for them. That's a really big sign that they're going through some type of emotional distress that is probably beyond them just temper tantruming. And we really want to pay attention if those things are happening over and over again in our kiddos under 6. So the mood changes and the behavior changes are what we're going to see most likely. So, they might be waking up in the morning and not really interested in doing things that they would usually, want to do. Like maybe they're not wanting to play as much. They're crying more often. They're withdrawing from their friends or their family members. And when they are playing, this is another interesting thing to keep in mind, is that you're seeing sort of themes from the traumatic events that happened come out in their play. And so we might see them reenact or like act out what happened using dolls or using different types of toys. A lot of the times you see, if they're playing a dollhouse, you see kiddos play out that the parent is hitting the child. Again, that's not coming from TV. Most likely that's coming from knowing that they had a trauma exposure, coming from their own experiences. Or they might have references to war or references to car accidents. It doesn't have to be that they play it out and act it out entirely, but they are bringing it up again and they are referencing it. And so those are very helpful for teachers, for little kiddos to keep in mind, as well as our parents, because again, kiddos are not going to come and tell you that I was traumatized and I need help. They're just going to communicate it in a different way. And if you're a parent, again, if you're noticing that there's a lot of changes they're happening and you just, again, you've had other kids, you don't understand why this is happening. It is likely not just a temper tantrum or a meltdown, and it's recommended that you probably do an assessment for these younger kiddos without waiting too long, because the earlier we intervene with any types of trauma exposure, the better, but especially with younger kiddos with their brain developing really quickly, and their treatment's much easier, their brain is much more elastic, and that when it's not treated, it's leading to much more worse outcome. I just wanted to highlight those differences in our little kiddos. Before I move on to depression. And, like I said earlier, a lot of the symptoms from PTSD look like depression. And we know that these two things happen often together. And usually you're coming in with a trauma, let's say. Oftentimes providers miss the depression piece because they don't think that they need to assess for it if it's PTSD. But, we see that they happen quite often together. And so we really want to make sure that if you're a provider, if you're either a mental health or physical health or a medical doctor, to be able to detect both of those things and not just one, because we know they happen together quite often. So one study, or one research statistic is that, majority, 96% of those with depression report traumatic exposure in their lives, but they don't always get an assessment for PTSD. And so it's helpful to always do that. And to keep in mind that we have about 50% those with PTSD meet for another depressive disorder at the same time. And then good news again is that the treatments are really good for both depression and PTSD. If you treat PTSD, oftentimes you're treating depression and substance use and other things that come with it. So that's kind of the good news there. And that the last thing is that it's not like a chicken or the egg question, because we know that when a trauma occurs, there's like a starting point. So the starting point is often the trauma. We have PTSD symptoms that come from that. And then we see that in most situations, depression comes after that. And so it's likely that the PTSD has impacted your life in a way that you're seeing those depressive symptoms come up, like I'm not eating as much, I'm not sleeping anymore, or I'm sleeping too much, or I'm eating too much. Those things are not specific to PTSD symptoms, but they might come from symptoms like the PTSD symptoms we talked about earlier. Because they're causing you so much distress, other areas of your life are going to start to be impacted as well. So depression is a big piece here. And I had put in substance use and other types of outcomes that come from PTSD. We just don't have enough time in the hour to cover those, but those are always important to keep in mind as well when it comes to trauma exposure. I'm just looking at the time. I'm gonna try to go through this within the 8 minutes so we can have the 30 minutes for questions, but there's not that many of us here, so I might spend a little more time on this. And if y'all have questions, just put it in the chat at any time. But we have
one
this
question already there about
I think we already answered that one.
the genetic predisposition.
Yeah.
So yeah. Okay, I'll let you continue. I just thought.
Thank you.
And then
Yes,
I will leave at 12:30 and I'll have you continue with the
Okay. All right. Thank you. So for trauma treatments, you know, we're gonna see them separate in general in the treatment world. We have adult treatments and childhood treatments. It's the same for trauma focused treatments. For adults, we have, I'm just gonna put up all of them. We have 3 really strong evidence-based treatments that people really successfully recover from their PTSD symptoms from. They're all types of symptoms, they're all types of treatments that have some type of exposure in them. And if y'all are not familiar with what exposure means, exposure really means that it's the type of fear that you have, whether it's a trauma or whether it's spiders or heights or even just social anxiety. The key is that you need to stop avoiding it so that you are not having those difficulties that come from avoiding it. And so with all of these adult focused trauma treatments, you are going to be talking about your trauma. Sometimes you're going to be writing it out in a narrative or in a story. Sometimes you're just going to be, you know, discussing why you think it's affected you, you know, in whatever way you're going to discuss it, there is exposure to the trauma that you have not had because you are avoiding it for so long and you have been avoiding it, that you're getting stuck in this cycle of I avoid it, I get more intrusive memories, and so I get more hypervigilant, and it's just this ongoing cycle. With treatment, you're cutting out the avoidance piece. You're gonna talk about it, you're gonna think about it, it's gonna be difficult, but it's short-lived. It's usually those therapies are 12 to 16 sessions once a week, you know, so in 4 or 5 months, people are seeing so much improvement when it comes to their trauma treatments, because again, the key is that you should stop avoiding it in a safe, supportive place. You're going to be able to think about it in a way that's healthy and helpful, and you're not going to be able to get stuck in this cycle. The first one is a little more cognitive based, meaning it takes a little more of the worldviews and thoughts about why this happened and who made it happen and why are you so stuck on it, versus prolonged exposure. It's a lot of exposure work, so you're just talking about it over and over and over again. You have to record yourself telling your story and kind of listen to it during the week, and so it's a lot of what we call homework. But it's, again, both are very, very effective, and it's just about the type of trauma that you've had. It kind of just depends, and your provider should be able to help you choose the best one for you. It should be a joint decision. The provider should not just choose on your behalf. If you don't want to be doing a lot of the processing of your thoughts and feelings and you want to just kind of come in, talk about it and be done, you know, maybe PE is better for you. But generally those first 2 are, and I put links in there for people to use. If I think we send the slides out, I'll double check with Dr. Khan, but there's a lot of misinformation on trauma treatments, and those are, you know, the main 3 that are evidence-based. And you can search for, you know, if you have an insurance policy, you can search through your insurance, who takes your insurance, you can search through Psychology Today, or if you're wanting a Muslim provider, you know, there's a bunch of Muslim networks that have Muslim providers on there, and if they have advertised that they do evidence-based trauma treatment, those are the best ones to start with. You know, whether it's CPT or PE or even regular CBT, you know, if a lot of the themes of trauma can be included in that. And then for kids, I'm going to move more on. I'm going to move for children and adolescents. We have a couple different treatments that are available. And again, if you're a parent, it's recommended that you don't go to anybody who advertises that they do trauma treatments. You really want to double check that they're doing evidence-based treatments correctly. And so trauma-focused CBT is a very successful treatment as well for kids. And then we also have a family-based one. And then for young kids under age 6, we use PTIT, or parent-child interaction therapy, because there's not going to be that ability to talk about your thoughts and feelings with those younger kiddos, and it's more behavior and more about the relationship between the parent and the child. The one thing I want to note is that for this one, the children and adolescents, your caregiver is going to be involved. You don't just drop off your kid and kind of leave for an hour and come back. You have to work with the provider as the caregiver. And that's why, you know, we don't see rates of success in child and adolescent treatments unless the caregivers are super involved in the treatment itself. And so, you know, just to really, you know, I don't want to spend too much time talking about how important parents and caregivers are, because we don't have the time, but it really is key that if you're gonna want to help your kid, you yourself have to do the work with them. It's not just like an hour where you drop them off and come back. But similar ideas, you know, the kid will go through an exposure of the traumas, depending on their age, talk about thoughts and feelings and learn relaxation skills and all sorts of things to help them be able to move on and not suffer from PTSD the next time they might have a trauma happen. All right, we have a couple more minutes. You know, I really just I have a few more slides, but it's not that important to go through them. I just wanted to see, you know, if let's say you're not the person who's struggling with this, it's not your kiddo, maybe it's just a friend or somebody that you know and you care about. I wanted to just highlight a few things that you might see that are not necessarily symptoms, you know, they're just kind of different things that we know people with PTSD might display, including not feeling very apathetic, you know, displaying or coming off as a little more apathetic and kind of doesn't care. You might see more statements or behaviors that you consider paranoid or a little bizarre. You might see more like a, you know, a provocative type of reaction. And you might see people who are showing themselves coming off as very unappreciative, or like, you know, they're pushing you away, they're very confused, you might see a lot of inattention, and all of those things, you know, happen, and there are symptoms of PTSD, but they're not like a clinical type of symptom. And so I really wanted to just emphasize that this is not a person being rude or, you know, being, you know, insensitive. It's because of the different traumas that they've had, they might come off this way. And it's not an excuse, right? I'm not saying you can just kind of forgive and move on. I'm just saying, if you notice those things, it'll be something helpful for you and them, perhaps to point this out to them, you know, if you're close enough and if you're a supportive person for them, that this might be something that you've noticed with them, and you know, okay, what can we do about this? How can I help you? And you also might see, what can you do is that you can just be mindful of how questions, or, you know, the types of questions that you're asking of these people that in your lives that you care about. You know, people who have been through traumas often are very in tune to, you know, guilt and shame. And so any question that is asked in a certain way might come off to that person as accusatory, or, you know, you're accusing me of this or that. And we want to avoid those types of tones and those types of questions, because it is very easy to kind of pick up on those. And then just kind of be aware of any physical contact. You know, a lot of trauma that's physically based leads to a lot of reactions for the person, and they're not able to accept or do any physical contact, even a handshake, you know, and so be aware of those types of contacts in general with people you know perhaps have been through a trauma. And then finally, just kind of be genuine, don't fake any empathy if you don't have it. You know, that comes off very easily as ingenuine. And also, this one is interestingly, you know, people have a hard time with, but when somebody discloses something to you or tells you like, this has happened to me and I don't know what to do and I'm struggling, you know, the recommendation in general is to avoid disclosure back, like, oh yeah, same thing happened with me. And, you know, you're just wanting to have a conversation with the person, and it's not coming from an from a malintention, but it doesn't always come off as supportive. And so we generally want to avoid any disclosures when the person themselves are telling you about something difficult that happen to them, you know, kind of just validating how they're feeling, and that sounds really difficult, and I'm really sorry that happened to you, and, you know, how can I help you, are usually our safe go-tos, instead of sharing back about something traumatic that you have been through, because they also may not be ready to hear that. That might be too much for them too. And I think those are the slides that I have. So I'm gonna, I think the last 30 minutes are more questions, and if people have specific things, but there's not that many of us here. So, you know, if anybody has a question, feel free to unmute, you know, feel free to put it in the chat. And yeah, thank you for listening, everybody. I appreciate it. I think Dr. Khan logged off, so it's, you know, there's no questions. Feel free to log off as well. Okay, I see one question. Thank you very much. It's very kind of you. For those of you who might want to ask a question, thank you, Aisha, I appreciate that. In a private way, you know, you can hold on a little until people log off, and then we'll be able to chat a little bit too. I know it's sometimes preferred that you don't ask a question in front of others. So feel free to kind of hang around if you have a question that you'd like to ask one-on-one. Okay, it may be that we don't have any questions, so I'm just going to end the presentation, y'all. And thanks again for attending. I appreciate it. This is recorded, so if people have questions later, you know, and you're watching this later, feel free to email me. I think that the email address will be correct on the YouTube link, and so y'all can just use that email. And yeah, thank you so much.